Hello, and welcome to the third module of HSM 375. For today's class, we'll be discussing clinical facility and public health data. There are three learning objectives for today's class. The first is we are going to discuss the role of measurement metrics, identify different types of clinical facility data, and identify and interpret different types of public health data. So, beginning with the metrics, this table should be kind of familiar with for you. A lot of the information here came from last module where we talked about PICO, and we have the outcomes here showing for case one, case two, case three. You might notice that the outcomes are generally measuring something. In case one, we are trying to determine whether Mediterranean diet is better for adults with history of health diseases than typical diet or vegetarian diet. And the way that is being measured is by looking at what's happening with reduction in heart attacks. And then with case two, in trying to determine whether people with hearing impairment have a different experience of discrimination and stigma from those that are visually impaired. We are measuring their respective perception of stigma and discrimination. And then in case three, we have where we are trying to figure out whether race plays a role in job satisfaction. And we're doing that by measuring the different rates of job satisfaction between white nurses and ethnic minority nurses. So that is basically outcomes are measuring something. They're measuring health outcomes. So what the outcomes does is that we're working very closely together there's a question the metrics are trying to answer, right? I'm just going to use the example of case one. With case one, the question the matrix is trying to answer is how do we know if Mediterranean diet is healthier for adults with history of health heart disease than vegan diet? I'm using vegan diets as an example in this case. This is not what science is saying. This is just an analogy. So there's the question that the metrics is trying to answer, right? And the way the metrics is doing that is by looking at hospital records for heart attacks. So, and they're going to compare the number of hospital admissions for heart attack between those who are on Mediterranean diets and those who are on vegan diets. So that is the metrics that is being used. Literally number of times when there has been an hospital admissions and that. So that is how metrics and measuring health outcomes coming. And then for case three, we have in trying to understand whether race plays a role in the experiences of job satisfaction. We have the metrics trying to answer the question of trying to answer this question by looking at the number of white nurses, how many of them say that they're satisfied with their job, and how many of them have left their jobs, and they are comparing this number, with the number of African American nurses who say they are satisfied with their job and how many have left the job. So that is what metrics do. And so when we have it all together, we then are able to make interpretations, and in our interpretations help us in identifying what the health outcome of a population is. For example, we know with the Mediterranean diet, we can say in order to avoid heart conditions or heart attacks, it's better for you to eat Mediterranean diet versus eating vegan diet, for an example. And in trying to have a conversation about race and job and employment, we can say, oh, African American nurses have lower rates of job satisfaction than white nurses and stuff like that. So we basically interpret data and use that in identifying the health outcomes of the population that we are interested in. So so that then takes us to clinical facility data. So, before I really get into that, I wanted to explain the difference between clinical facility data and public health data. To do that, I want to explain how clinicians approach health versus how public health or population health approaches health. So, clinicians kind of do that from the perspective of the individual. Public health does it from the perspective of the population. So you might say, but individuals are part of the population. Yes, but clinicians kind of hone in to the individual and what is going on in there. Public health or population health is a lot less interested in what is going on an individual basis, but looking at it from what is going on from a population basis. I'm going to explain in an example. So, clinicians are trying to solve your personal health issues. Populations or public health are trying to solve a population health problem. An example is, let's just for example, you are asthmatic and you one day you find yourself having breathing difficulties, and because of as a result of that you get to the ER, and when you're there you describe your symptoms to the nurses and or the attending physician. They'll run their tests, they'll do their diagnosis, they'll prescribe a medication. You take the medication and voila, you're good, you're breathing, life is good. And they discharge you and ask you probably, come back in a week. And then if everything is okay, then you're all good, right? The whole process of when you get into the hospital, even to the point where you call 911 and data is being collected from the hospital, from you, the demographic information is being collected, your insurance status is being collected, what types of symptoms you have, what the diagnosis was. Even if you have had diagnosis before, you're having worsening symptoms and all the rest of that, the medications you were prescribed. There's a whole lot of information that the clinicians are collecting from you, your charts and everything, all that information that they input there. That is very important. That is what we call the clinical facility data. And this data is collected the time you encounter the healthcare ecosystem. It comes from your data record, your insurance information, your healthcare success, and even we in the area where there's a lot of individual generated data. For example, those that are coming from wearables like Apple Watch and Fitbit. So I have an Apple Watch, and with the Apple Watch comes with Apple Health. The way that my Apple Health works now is that there are some hospitals, none of them in Hammond though. There are some hospitals that you can directly feed into their system. I think it's Epic system, that through your Apple Health. And there's some kind of interaction between my chart and my Apple Health. So you have all of this interface, and all of them are all places where the health of an individual gets being collected, and decisions can be made from an individual level, individual perspective. An example of clinical facility data would be the hospital acquired infection. So There are a number of standardized clinical facility data, the same way as a number of standardized public health data. And hospital acquired infection is one of them. I'm going to talk about two other ones, but this is not to say that these are the only clinical facility data. And, from where what you see here, you can imagine that there are multiples of data that are coming that are sourced through hospital facility or clinics facilities. So, but for hospital acquired infection, you can also call them healthcare associated infections or hospital acquired conditions. So, basically, what they are the diseases and disorders that occur to a person while during the time that they are in a healthcare facility. Uh, I would use an example of, let's say, for instance, you had a heart attack and you went to the hospital and you were, admitted and all the rest of that. And during the period that you were on admission in the hospital, you get COVID. Now, COVID for you then becomes a hospital acquired infection. So, that is a way to help you kind of understand what that means. So, these infections kind of happen during the process by you are receiving treatment from medical or surgical conditions. So, they can happen through all settings of care. It could be in the hospital, it could be on the ambulance, it could be nursing homes, rehabilitation centers. They don't necessarily have to be only in a hospital before they can, classify as HAI. So, another type of standardized clinical facility data would be patient satisfaction. With the patient satisfaction, is more or less treated as an indicator of how well patients are being treated. In terms of being treated, they're looking in terms of the quality of care, whether patients were satisfied with their hospital visits or, whatever encounter they had with a healthcare professional. And it's also used in determining care quality. For example, what are the things that patients are finding valuable, those different aspects of healthcare that patients consider valuable. So there are a number of things that are used for that in the forms. Some things are quite standard. An example would be looking at in terms of communication with nurses, in terms of discharge interactions, in terms of overall hospital ratings and stuff like that. Um, Unfortunately, and this is me speaking personally, unfortunately, I have not been good with patient satisfaction in terms of filling it out. Uh, I get the emails and I just don't click on it. So that is really bad. And this is me just saying. And unfortunately, I imagine there are quite a number of people that are, that could be like me, who get this patient satisfaction forms that are not filling it. I should imagine that that kind of presents some challenge for, the reason why these forms are being collected in the first place. And anyway, a third standardized metrics would be consultation rate. With consultation rate, we are looking at in terms of number of outpatient consultation per person per year, and is kind of used as an indicator of accessibility and utilization of healthcare services. But it can also be a reflection of the quality of the healthcare services. Now, I'm going to give you an example whereby it is a reflection of accessibility and but not a reflection of quality. Let's say, for instance, there is this, really sophisticated healthcare facility that is built, but it's really being run on robots and computers and stuff like that. Some of us who are technologically challenged persons will, if we go and have one singular visit in that place and find out we are lost half of the time because we can't find anything and we can't understand anything, we are not likely going to visit again. We're going to possibly go and look for another facility that is a lot less techy, but a lot more easier to use. So in this case, the consultation rate would be giving information on in terms of accessibility, which would mean being low. Imagine in a situation whereby there are more technologically challenged people like me, then it would affect accessibility and will affect utilization, but that may not necessarily affect quality of healthcare services. Still have very good quality. It's just that there's other things that are making it difficult or less accessible to people, and therefore they're not utilizing it as much as they need to. So, consultation rates does not necessarily measure a coverage of an area in terms of how many people that's the hospital can serve. It doesn't really focus on that, but it does collect the numbers of the average number of clinic visits that they are in a defined population. So this quotation is from UN Office of Coordination of Humanitarian Affairs, which I would advise that you click on this. And it, about consultation rate, it says that low rates are indicative of poor availability and quality of services. For example, several countries have demonstrated that outpatient department rates go up when constraints to using healthcare services are removed. So that gives you a sense of how consultation rate is connected to accessibility, utilization, and could be quality of healthcare services. So that's where we'll end with clinic facility data. And then let's move into public health data. So I kind of explained to you guys how public health looks at health from a population versus the way clinicians do. So with public health, it's kind of looking at the health of the people, and it does so by collecting data from the population. And using asthma for an example, that like I use for clinical facility data, the public health data would be looking in terms of how many people in that neighborhood, how many people in that state, how many people in the county, stuff like that. How many people have asthma? Now, they may get this information either through hospital records, for an example, in terms of the number of diagnoses that they get, or hospital visits that are related to asthma or something like that. That's one way they can get that information. But they can also get it by asking the people in the neighborhood directly. So there are a number of ways that information like that can be obtained. But beyond just talking about how they are obtained, there's something that public health goes a little bit further than clinicians when it comes to the data that they collect. So public health is looking in terms of, okay, so we know that this is the number of people who have asthma in this neighborhood, but are there some similarities between these people who have asthma? Are they children? Are they children from low income families? Are they children from low income families who live near an industrial zone, for example? So now let's say that they do find that there are more of the asthma diagnosis is happening with children who are low income and live near industrial area. They could drill down even further to look at it in terms of, okay, is this happening for children who have regular doctors versus children who don't have regular doctors? So these are some of the questions that public health data does ask, that makes it go beyond what clinical data collects, and the kind of question that is able to ask from there. However, so in a nutshell, data collected from health hospital visits or any interaction with the healthcare ecosystem, clinical facility data if data is collected, through public health surveillance, is a public health data. In case if you're just hearing public health surveillance for the first time, you can click on this link and it will take you to CDC, and it will explain what public health surveillance means. At the end of the day, both types of data are very important, and you can have them both working hand in hand. With case one, the one with the Mediterranean diet, the information may be coming from clinical facility, but it can get extrapolated to public health, whereby you can have public health campaigners use that information when they are trying to raise awareness about preventing heart attack. And then with the case two, you can have whatever data that comes from public health, and use it when clinicians are interacting with their patients as a way of making them become more inclusive and not engage with patients in this as if they have the same experience of discrimination and stigma, because it may not be the case. So there are a number of standardized public health data. One is the incidence rate. With the incidence rates, is kind of looking at things like how quickly does a disease occur in a population. And what that does is that it really allows for comparison between different population and time period. Incidence rate is one of those standardized metrics that can almost be applied in different settings and different diseases. So they are quite versatile in terms of how you can use that to collect data. So how incidence rate is generally measured is per 100,000 people. That should give you a sense of just how many people we think in terms of incidence rate. So if you're going to look about incidence rate, you're not going to be thinking in terms of 10 people. You're not going to use 10 people to measure incidence rate. Incidence rate is looking at millions of people, hundreds and thousands of people. So it's at a much bigger magnitude than the kind of data that facility collects. So, and those numbers are kind of expressed in terms of number of person affected per 100,000 of the population per year. So incidence rate is kind of looking at it from a year perspective. So this is very essential in determining the spread of a disease. For instance, if the incidence rate is really high over time, we could be thinking in terms of we are being encountered with an epidemic, like it happened with HIV, or we could be dealing with a pandemic, like it happened with COVID. And so, incidence rate is one of the things that we use to determine one of those stuff. So on the hand right side, we'll give you an example of what how incidence rate is being measured in this case. This is from the American Cancer Society. You can click on this link. If you click on the image, it will take you to the link, and so you see more information that is given on this and seeing how incidence rate is being presented. Then the next rate to talk about is prevalence rate. So prevalence rate is kind of looking at it from the angle of proportion of persons in a population that have a particular disease at a specific time or over a specific period. So this may be looking like too many words, but I'm going to explain it. So prevalence differs from incidence in the sense that prevalence is looking at everybody that have the disease, right? Whether it's new or whether it's pre-existing. I'm going to use COVID as an example. When we start talking about COVID, particularly now that the incidence rate has kind of dropped, it's not as high as how it was 2019, 2020, 2021. Although I think China is still dealing with very high incidence rates, but for the most part, we've kind of tapered off incidence rate. There's a lot that is being focused on prevalence. So with prevalence, we are looking at how many people in this population within this time have this disease. That's what prevalence rate is looking at. This could be looking at in terms of the new people who are having this disease, as well as all the existing people who have the disease. So if we are talking about prevalence rate of COVID, we'll be looking at the people who got COVID, saying 2019 to 2020. This includes if there is a new infection, there's a new infection tomorrow, the new infection becomes part of the prevalence rate, because prevalence rates, accounts for everybody. So incidence rate, remember, is only limited to new cases. That's not how prevalence rate is. So right hand side is also a visual representation of incidence rate. Is also a link that takes you. This is that will give you a much detailed explanation of what that is like. And then we talk about mortality rate. So mortality rate is kind of looking at frequency of the occurrence of deaths in a defined population during a specified interval. Long story short, how many people died within this period, within this number, within this time frame. That's what mortality rate is looking at. And mortality rate is also expressed in terms of per 100,000 people. And so how to look at incidence rate, like connecting incidence rate plus mortality rate plus prevalence rate, is I'm going to use this image as an example. You have this bath, the water that is going in, that is the incidence rate. The water that is already in the bath, that's the prevalence rate. The water that is pouring out, that is the mortality. So the mortality, you're coming out from the prevalence, and incidence is going into the prevalence. So that is how you can think about these three things, how they connect in terms of health data. So you can also go to this link over here. This image links you to a paper that would kind of give you a little bit of an example of what's going on in terms of mortality rate with a specific disease condition. So sometimes when research is being done, they are not just looking at incidence rate only, or prevalence rate only, or mortality rate only. They could be looking at all three of them or at the same time. Like in this study that is looking at prevalence, new rates, new cases, and deaths of HIV, and is looking at it from 1990 to 2019. So you can have studies that are looking at all three of them. You could also have studies that are going beyond just these three. So while I only mentioned three public health data, it doesn't mean that that's all that there is. There are more. There's so many more. Please check chapter 6 of the textbook. That is where you're going to find a whole lot more that is discussed. And then chapter 5 of the textbook discusses much more of the clinical facility data. So read chapter 5 and chapter 6 to give you a much broader or more detailed information of difference of this the data categories. I hope this answers your question. Sorry, I hope this is helpful to you. If you have any questions, there's something you need further clarification on, do remember to use the Q&A board to seek clarification. And do have a lovely day. Bye.